Today, I will finish off on the heart with you. And then what we can do is the next session, we can start to look at the embryology of the heart. So we'll finish off with the heart today. And I'll just talk about, I'll link the nervous system in as well, because we started to talk about the electrical conductivity of the heart. And then we started to look at some pathologies of the heart. And so today, what I'll do is I'll just finish off with that. And also I'll finish off with the last bit, which is to look at the great vessels of the heart. And then we'll look at the thymus. And then we'll also just consider some pathologies around the great vessels. So that kind of just finishes off with the heart. And then it leads us on to the next bit, which is just to kind of go back to the beginning and look at how the heart develops. So there's kind of two ways you can do it. You can either start off by looking at the embryology of the heart, which is normally how I do it, and then go through the heart, or you can actually go through the whole of the heart and then look at the embryology. And, both ways work. So, we'll look at things like aortic aneurysms, we'll look at aneurysm repairs, aortic dissections, and then we'll look at things like these congenital changes, which will kind of link onto the next section. So I shall take it to the beginning and we will go through this next part. So this is the kind of the last part in relation to the heart. So I started to talk last session about the electrical activity, or how the central nervous system and the peripheral nervous system works in relation to control of the heart itself and cardiac output. So what we also need to consider is we need to consider how breathing is regulated. So we have a neurometaxic area which controls the degree of lung inflation and it inhibits inspiration. So we're going to look at how that works. And we have an apneatistic area which is responsible for the promotion of inspiration. So we're going to look at how these work and how they control the overall regulation of breathing. There's a medullary rhythmicity center, and this is where we see the nerves extending into the intercostals and the diaphragm. And so we're going to look at that as well. And we're going to look at how the intercostal muscles, which we've looked at and we discussed in our first few lectures, and the diaphragm work, and how much overall percentage they form for normal inspiration to occur. And these signals are automatically sent, and we have an expiratory center which is activated during forced breathing, during forced respiration. So this is essentially what we have. So I'm just going to make some notes for you here so you can see. So here we have the region of the pons, and here's the medulla oblongata, and we have a stimulation and inhibition center. So here we have the apneistic center and the neurotaxic center. So these centers are responsible for inhibition, the neurotaxic area, and stimulation by the apneatistic area. And the rhythmicity center, which is controlled via the ventral respiratory group and the dorsal respiratory group, or the VRG and the DRG, communicate this stimulation to the intercostal nerves by the internal and external intercostal nerves. And of course, we also have the communication with the diaphragm. So the diaphragm, as you know, really a key important structure for respiration. So the combination of the diaphragm and the intercostal muscles are key for the stimulation of the respiratory system. So chemoreceptors, breathing can be controlled up to a point. So up to a point, we can control our breathing. We can control if we take a nice deep breath in and how much of an expirational force we use. But things like too much CO2 will stimulate the inspiratory area, and the phrenic and the intercostal nerves will therefore be innervated. And the central chemoreceptors within the medulla oblongata monitor CSF, and they monitor for changes in things like pH within the cerebral spinal fluid. They look for changes within pH within the CSF to see what's going on in relation to chemical changes. So if we just look at a kind of basic schematic here, very, very basic. Here we've got the brain and we've got the sensory nerve fibers. And here we can see the vagus nerve, and the vagus nerve coming down through the carotid sheath, down via the carotid artery. And then here it's going to loop round, become the recurrent laryngeal. So you've got the left side and the right side. You can see that we have an important communication to the heart via this region, which is going to be where we're going to look at today. So this is where we're going to concentrate on today. We're going to look at the great vessels of the superior mediastinum. So this is everything at the top of the heart. And we're going to link to how the nerves get to this point and start to communicate with not only the function of the heart, as we started to look at in our last session, but also how it communicates with the function of the pulmonary system. So these peripheral chemoreceptors, I'm just going to make notes for you, some highlights and points, because these are the most significant things. You've got the aortic bodies, which of course are within the aortic region via the vagus nerve, because the vagus nerve is going to travel in the carotid sheath. And so within the carotid sheath, you have your, within your aortic bodies are going to be within the aortic region, but that's going to be communicated within the vagus nerve, and the vagus nerve is going to travel to the aortic bodies within the carotid sheath. I went the wrong way around there. I'll come back to that in just a second. The carotid bodies are within the carotid. So this is where we find within the carotid artery, you have a carotid artery, jugular vein, and the vagus nerve all going down through the carotid sheath, communicating via the glossopharyngeal. This responds to fluctuations in blood O2, CO2, and hydrogen levels. It's a rapid response. We have pulmonary stretch receptors, and these prevent overinflation of the lungs and ultimately promote expiration. So these are our peripheral chemoreceptors. So the aortic bodies via the vagus nerve, the carotid bodies via the glossopharyngeal nerve. The glossopharyngeal nerve through the carotid bodies respond to fluctuations in blood, O2, CO2, hydrogen levels, and it's a rapid response. And we have our pulmonary stretch receptors, which prevent overinflation of the lungs and ultimately promote expiration. So that these are the only 3 points you need to know in relation to the chemoreceptors, peripheral chemoreceptors. So aortic bodies, vagus nerve, carotid bodies, glossopharyngeal, pulmonary stretch receptors. So there's 3 muscle groups of inhalation. So we started to talk about these muscles and we kind of looked at the intercostals and we went through them in quite a lot of detail. But now what we're going to do is, this is going to be particularly useful for you, especially when you have patients who, especially with this current pandemic, thinking about things like COVID, this will be particularly relevant, pertinent to you for oxygen saturation, to work out oxygen saturation levels. And there was an interesting study, which I'll send to you, which was about osteopathic manual manipulation of the sternocostal region to promote oxygen saturation levels in COVID patients in the United States. Because a lot of DOs in America, they're also fully trained physicians, but they also are osteopaths. So they do a lot of work in general medicine. And they did a really interesting study, and they found that by doing a lot of the thoracic manipulation, and they did like the chest pump, I forgotten what it's called now, but I'll send you the paper. They actually found that they could improve saturation levels by 2 to 3%, which is significant. It's a very, very significant change. And so this kind of links into that. So we've got 3 muscle groups of inhalation. We've got the diaphragm, the external intercostal muscles, and the accessory muscles. Now, what I really want to do is to talk to you about how these muscles of inhalation work in clinically. So I want to make it pertinent to you. And the point that I want to note is the percentage of air movement that these are responsible for. So the diaphragm contraction draws air into the lungs. So that is the primary function of the diaphragm. It increases the transverse diameter of the thorax. So it increases transverse diameter. And it's responsible for 75% of normal air movement. So this is a huge amount. So what I'm saying here is if you get unilateral diaphragmatic paralysis, you lose half of this. If you get bilateral diaphragmatic paralysis, you lose 75% of normal air movement. It's not compatible with life. It's a huge amount. Okay, so 75% is controlled by the diaphragm. But what people forget is that 25% of normal air movement is controlled by the external intercostal muscles. So they assist in inhalation. Now, we started to talk about cases a few weeks ago, and we started to look at things like multiple rib fractures and flail chest and things like that. So this really links to this, because when we have cases like that, where we have multiple rib fractures, overriding ribs, and complications like that, this 25% of normal air movement is affected. So although the diaphragm may still be working fine, the additional 25% can be greatly affected in these cases. And therefore, this may be a patient who has had an injury over maybe many years ago, in fact, but now has other kind of chronic obstructive airway diseases and problems like that. And so as an osteopath, you can help with this. This would be the area in which you'd be helping at. And in fact, this is specifically the American Osteopathic Association paper is to do with manual manipulation of the thoracic region. It's called the thoracic pump. The thoracic pump, that's the one. And things like the thoracic pump and other maneuvers that they're using, this is where they're working at. They're concentrating on the external intercostal muscles to try and build up this extra 25% of normal air movement. So very, very interesting. This really is a very important point. So we also have, as you know from your training, we also have accessory muscles which assist in elevating the ribs. And so these muscles are things like your sternocleidomastoid, your serratus anterior, your pectoralis minor, and the scalene muscles. Now, I'm also going to link a bit of clinical stuff into this as well. What do you see? Now, I know you probably have had many patients who've got asthma. What's one of the signs that you see with the accessory muscles in asthmatic patients?
So they'll normally have upper rib breathing, and they'd be tight in the scalenes.
Yeah, excellent. Yeah, so they get upper rib breathing, and they have the heaving. They kind of heave on their chest. It looks like they're having to drag their chest up. So yeah, they have to use the accessory muscles. So like the sternocleidomastoid muscle, the scalene muscles. Sometimes in patients who've got long-term chronic obstructive airway disease and things like that, you can see really defined musculature in the neck because the muscles are having to work so much harder to kind of raise up the ribs and to assist with breathing. I'll also just mention about serratus anterior. You do see this on humans, but mostly on animals. I did several years ago, I went and did a guest lecture in a veterinary school on comparative human and animal anatomy. I was doing a lecture on dogs and the heart, the cardiovascular system and the respiratory system of dogs in relation to humans. And one of the other lecturers was a horse surgeon. And we started to talk about this very subject, as you do. And he said to me, you know, something very interesting. He said, you know, horses also get things like asthma and breathing disorders. And one of the things, and I said, oh, really? He said, yeah. And I said, oh, so do they get the kind of accessory muscle? Do they get like, do they have to use accessory muscles? He said, yeah, we look for something called heave lines. And heave lines are seen within the serratus anterior. So horses, as you know, you see they're beautifully muscular creatures. You can see the muscles really nicely. So on horses that are suffering from pulmonary problems and pulmonary diseases, the serratus anterior becomes more enlarged. So that's their accessory muscle. So that was just a little bit of, I slightly went off topic there, but so you don't tend to see it so much in humans, but in animals, in horses particularly, you see an enlargement of the serratus anterior. In humans, it tends to be the scalenus and even the sternocleidomastoid, but mainly the scalenus muscle. So now let's look at the sequence of events and start to kind of put it all together. So, and we'll look at some imaging as well. So I've got some X-rays as well, so you can see the difference in the X-rays. So I'm going to just show you the different parts of the X-rays as well. So here we have the first process. So this is inhalation, and I'm going to just show you what the muscles do in this and how this appears as well. So we've got a sequence of events. So we have inspiratory muscles contract, the diaphragm descends, and the rib cage rises. The thoracic cavity volume increases, the lungs become stretched, and intrapulmonary volume increases. So this is all happening in inhalation. So inspiratory muscles contract, the diaphragm descends, rib cage rises, thoracic cavity volume increases, lungs are stretched, intrapulmonary pressure increases, intrapulmonary volume increases, intrapulmonary pressure actually drops, and the air or the gases flow into the lungs down its pressure gradient until the intrapulmonary pressure is zero. So this is what's actually happening during inspiration. The scalene muscles are going to elevate, first and second ribs. So the scalene is going to elevate. The inferior part of the sternum is going to move anteriorly. So this is going to come forward. The external intercostal muscles are going to elevate the ribs, and the diaphragm is going to move inferiorly during this contraction. And so here, if we look at the lateral dimensions, you're going to see the external intercostal muscles contracting, and the diameter and the anterior and posterior diameter is also going to become more significant. The ribs, the changes in the anterior and posterior, superior, inferior dimensions. The ribs elevated, the sternum flares as external intercostals contract. The diaphragm moves inferiorly during the contraction. And so what we'll see on our X-ray are the following points. So remember, we have our costodiaphragmatic recess. our costodiaphragmatic angle. So now what we're going to look at when we see this image of the X-ray is the whole border of the lung is going to fill the angle and the recess, and we shall see that the ribs, the spacing between the ribs, there will be expansion between the ribs, and the whole of the chest will be expanded, and we'll see that the diaphragm has moved downwardly, as opposed to when we look at exhalation, where we see the opposite. So with exhalation, we're not going to see the costodiaphragmatic recess and costodiaphragmatic angle filled by the lungs, and we're not going to see the diaphragm fully down. We're going to see that the diaphragm has moved. Also, the intercostal angle space, there will not be as much of a diameter, and there won't be so much space on the lateral borders of the ribs as well. So we're going to look at that in a bit more detail. So muscles of active exhalation, we started to talk about this last week. So we've got the internal intercostal and transversus thoracicus muscle. This is going to depress the ribs and decrease thoracic volume. So this is active exhalation. The abdominal muscles are also going to be involved. They're going to compress the abdomen. They're going to force the diaphragm upwards, and they're going to forcefully contract while coughing and sneezing. And so this is what we have. This is the sequence of events in exhalation. So the inspiratory muscles relax, the diaphragm rises as opposed to inhalation, where it falls. The rib cage descends during recoil of the costal cartilage. Thoracic cavity volume decreases. Elastic lung recoils passively. Intrapulmonary volume decreases because we're not taking air in. Intrapulmonary pressure increases, so it does the opposite because we now don't have the pressure. The air gases flow out of the lungs down the pressure gradient until the intrapulmonary pressure is zero, because it's going to do the opposite. So what's happening in relation to the muscles? Well, the transversus thoracicus muscles are going to depress the ribs. The internal intercostal muscles are going to depress the ribs. The diaphragm is going to move superiorly because it's going to relax. And the inferior part of the sternum moves posteriorly. So, when the patient takes a deep breath in, you see the chest expand, everything comes forward and outwards, and then as they breathe out, it all goes the opposite way. The changes in the anterior, posterior, and superior, inferior dimensions, the ribs and the sternum become depressed as the external intercostals relax, and the diaphragm is going to move superiorly as it relaxes, and the lateral dimensions, you're going to get your external intercostals are going to relax. And so instead of having expansion, it's all going to come in. And so what you will see when we look at the two X-rays comparatively, you'll see that in inhalation, of course, we've got, the opposite happening because we're expanding the chest. You can see that the ribs are splayed apart, the lateral dimensions increase, the diaphragm hits the floor, the apex of the lungs are visible, the costodiaphragmatic recess and the costodiaphragmatic angle are filled by the lung, as opposed to exhalation where everything is the opposite way. The diameter of the ribs is reduced, the lateral dimensions of the thoracic cavity are reduced, the windows, the costodiaphragmatic angle, recess and angle are not visible with lung fields or lung tissue. The apical part of the lung is also not within the cervical region. So that's a significant change. And it's a good one just to remember for yourself for looking at imaging, so you can see whether a patient has got an inspiration APPA radiograph or an inspiration AP radiograph or expiration AP radiograph. So inspiration and expiration just together. So sequence of events, as we've said. So inspiration, inspiratory muscles contract, diaphragm descends, thoracic cavity volume increases, lungs are stretched, intrapulmonary volume increases, intrapulmonary pressure drops, air gases flow into the lungs down the pressure gradient, expiration, inspiratory muscles relax, diaphragm, ribs rise, rib cage descends due to the recoil of costal cartilage, thoracic cavity volume decreases, elastic lungs recoil passively. We've got the intrapulmonary pressure, which is going to rise because we're doing the opposite, and then the air gas is going to flow out the lungs. And so just remember your changes in your superior, inferior dimension and your changes in your lateral dimensions. Those are the kind of key things to remember. So let's link it back to some of the things that we have started to discuss in relation to things like asthma. And then we're going to look at the great vessels of the superior mediastinum to finish off with the heart. So asthma is the most common one that you're going to come into contact with. So it's a chronic inflammatory disease of the small bronchi and the bronchioles. It's characterized by bronchospasm and air trapping. Outflow is impaired, and there's hyperelastic mucus glands in the bronchi become hypertrophied, the smooth muscle, we have edema and marked inflammation. And then at some point, hopefully in the not too distant future, we'll start to look at the pathologies of these diseases and start to look at the histology and look at the normal histology of the tissues and look at how they change. Do you remember we talked about another condition to do with remodeling of the airway? Do you remember what that was called?
Remodeling of the airway.
Yeah. We talked about it, I think probably about 2 weeks ago. We went through, and we were looking at different pathologies of the lungs. We talked about COPD, chronic obstructive pulmonary disease, and I was talking about a specific thing that actually remodels parts of the system.
It's not the you told me about. It's not when it gets to the primary bronchioles, and it's like basically it's a piece of what the hell was it? It's not it's bronchiectasis.
Yes, brilliant, perfect, excellent. Yes, very good. Yeah, bronchiectasis. Yes, bronchiectasis is where we actually get a change, and so asthma not the same, because with asthma what's happening is the inflammation is causing this to cause airway to cause overall airflow to be impaired. With bronchiectasis, it's actually become remodeled. So it's just good to kind of think about the two and just kind of relay them back, because they're similar but yet different. Because bronchiectasis is there's a constant change, or because the whole structure is changed as opposed to inflammation. So this is to do with inflammation as opposed to remodeling. So asthma is triggered by things like irritants. So it's triggered by inhaled irritants, and so we can have allergic, type 1 hypersensitivity, things like secondhand smoke, occupational, exercise-induced, infectious, other things like drug reactions, emotional stress, air pollution. All of these things can cause asthma, even exercise as well. So you can get exercise-induced asthma. So although exercise can help greatly with asthma, it can also, in some patient groups, cause it. So it's always worth considering getting good history with your patient when it comes to a patient who's got asthma and finding out what kind of triggers they have. So now we're going to look at the mediastinum to finish off with the heart. So the mediastinum, as you already know, is the middle region of the thoracic cavity, and it's divided into a superior and inferior region by an imaginary horizontal line. And it extends from the sternal angle, which I remember we talked so much about these angles, and I said T2, T4. So this is where it all comes together now. It all plugs in because these levels become so significant. So we've got this imaginary horizontal line, and it extends from sternal angle, which we talk so much about, or the sternal angle of Louis, to the intervertebral discs between T4 and T5. The inferior mediastinum is further subdivided by the pericardium and heart into an anterior, middle, and posterior. And so we're going to look at all of these regions today. So what we've got here, this is kind of my favorite picture when I talk about this, is we're having a cross-section through. So we've got a lateral view of the chest, and we can see the position of the heart. So this is going to be the anterior chest wall. This is going to be the posterior part. And here we have the region of the superior mediastinum. So we're going to just look at that. So let's just add some points to where we started to talk about a few weeks ago when we talked about our levels. So this is going to be your jugular notch or your sternal notch at T2. This, of course, is the nice bit that you can palpate. Then you're going to run your 3 fingers down the manubrium to the region of T4. And then, of course, at this point, T4 is your sternal angle or your angle of Louis. And so this is where you feel down from your jugular notch, 3 fingers down to your sternal angle. All of this is the manubrium. And so this corresponds to the level of T4. And so this would be the superior mediastinum. So there's a lot of very, very important things going on here. Everything below we see here, which is the inferior mediastinum. So this is the superior mediastinum. This is the inferior mediastinum. You have an anterior mediastinum, which is going to be on the front, a middle mediastinum, and then a posterior mediastinum. So the posterior, of course, is going to be at the back. So not too complicated, at all. So anterior at the front, posterior at the back, middle is in the middle. And it all, of course, is sitting on the diaphragm, which is the floor. And so superior mediastinum is the bit that we're really going to kind of concentrate on today. So again, just another picture showing the same thing, T2, T4, manubrium, body of the sternum, T8, T9. This is, just add that bit because that's also significant for you, especially as an osteopath, because you're going to work on the bones. So T8, T9. Then that's going to be behind here. You're going to have your central tendon of the diaphragm. So when you have your patient who's got some kind of respiratory condition and you're looking for the movement of the chest, you're going to be looking and feeling around this region as well. So I just want to just go through a couple of structures with you at this point. So here we can see the first rib. So here is the first rib. We can see the scalenus muscles. We can see the trachea. Now here we have, of course, the heart. And here we have the ascending part of the aorta. We have the arch of the aorta. And then we have the descending thoracic aorta. And what you'll notice is the very, very, very close communication at this point between the ascending aorta, the arch of the aorta, the trachea, and the left primary bronchi, and posterior to that, the esophagus. So here is the esophagus. So right here, it is all right next to each other. It's all really, really, really closely intertwined. So you can imagine anything that goes on here, like an aneurysm or cancerous growth or trauma, is going to have a huge impact on not only the arterial system, but the pulmonary system, and sometimes the gastrointestinal system as well, because the esophagus is also within this part. So what we need to know is the contents of the superior mediastinum. Very important. So we've got a thymus gland, which is largely involuted and replaced by fat in the older adults. We have the brachiocephalic veins. We have the superior vena cava. We have the aortic arch and its 3 arterial branches, which we need to know. We have the phrenic and the vagus nerves, the thoracic duct and the lymphatics, the trachea, and the esophagus. So these are all of the structures that we need to know within the superior mediastinum. So as I say, there's a lot of stuff going on here, and it's all in close proximity. So there's a lot of things and loads and loads and loads of clinical correlation, especially when you think about these structures: aorta, superior vena cava, brachiocephalic, phrenic and vagus nerve. So much stuff to talk about. So let's just look at the thymus. So it's a flattened lymphoid organ. It's located to the superior anterior mediastinum and the lower part of the neck. It has an arterial blood supply from the internal thoracic artery. It has a venous drainage into the left brachiocephalic vein, and then the brachiocephalic vein is then ultimately going to dump into the SVC. It consists of 2 lateral lobes placed in close contact along the middle line, and it extends from the 4th costal cartilage, this is relevant to you, upwards as high as the lower border of the thyroid gland. And we won't kind of go through the histology of it yet, because we're going to talk about that another day. So it's the site of T cell secretion, selection and maturation. The T cells originate in bone marrow, but mature T cells must migrate to the thymus to mature, selected for the ability to recognize self-HLA antigens to allow antigen presentation. Again, we're going to discuss this as we kind of go through the histopathology of all of this later. And the T cells with strong autoreactivity become deleted, which prevent autoimmune reactions. So again, we shall discuss this a little bit later. I just want you to just know the relative position of it for now. So what we have here is another image in which we can see, let me get my pen. So here what we have is the anterior chest opened up, exposed. You can see the right and left lung moved either side, and you can see the position of the heart, the pericardium surrounding the heart. And up here, which is where we're concentrating on today, the region of the superior mediastinum, you can see the thymus gland. So if we were then to remove the thymus gland, we could start to see the great vessels. So we would see the superior vena cava, the left and right brachiocephalic, and we're going to see the other great vessels, which we're going to look at. So the first thing we're going to look at is the brachiocephalic veins. So we'll look at the veins. We'll look at how the veins drain the costal region into the brachiocephalic, and then ultimately how this leads into the superior vena cava. So we've got the brachiocephalic veins. They're formed by a union of the subclavian and internal jugular veins of the corresponding side at the level of the sternoclavicular joint. So I'm just going to show you this, and then I'm going to talk about some very interesting cases for you. And they merge to form the SVC, superior vena cava, and they have no valves. So now what I'm going to do is I'm going to make this clinically pertinent to you. So I'm just going to get a different ink color so I can show you these points. Right, pen, color color blue. Okay, so here we have the right brachiocephalic, and here we have the left brachiocephalic, and here we have the superior vena cava. So here we're going to have this is going to be the jugular. So this will be your right jugular, and this will be your left jugular. So do you remember, I think last week we started to talk about left-sided and right-sided heart failure. And when we started to discuss right-sided heart failure, one of the things that we talked about was jugular venous distension. And so hopefully this will really clear up why we see that. Because what is happening ultimately, I'm going to just kind of draw in the border. Imagine that this is the border of the heart. So this, of course, is going to be the right side of the heart. And so the right side of the heart, as we already know, and as we already discussed, is responsible for the deoxygenated blood, ultimately in the region of the SVC, the superior vena cava. The deoxygenated blood is going to want to get back into the right atrium, into the right side of the heart. Now, if the right side of the heart isn't working, the blood which is supposed to flow this way can't do so, and then is going to backtrack. And that's when we're going to get things like our jugular vein distension and all of the other complications that we started to discuss. There's also another thing to consider here as well. Now, what you will see here is the esophagus. Here is the esophagus. And you'll note that the veins of the esophagus are going to communicate. In certain cases, we have something called the azygous system and the hemiazygous system. On this part here is called the azygous system, and this is where we have our hemiazygous system. And what you will see is that the veins are actually draining from the esophagus into the brachiocephalic and then back into the SVC. And also you'll see that the intercostal veins are also doing the same thing. So the intercostal veins, which drain the intercostal, external, internal, and transverse thoracicus muscle, are going to drain back in some cases directly to the SVC, and with the higher parts, they drain, and in relation to the hemiazygous system, they actually drain into the brachiocephalic. So, you know, why is that important? Well, it's important because what you can have in right-sided heart failure, not only will you get issues with jugular vein distension, but when you do a chest imaging, you can also find dilatation of the veins of the esophagus. And in some cases, in severe cases, you actually can find dilatation of the vessels within the drainage for the intercostal muscles. So these become enlarged. Now, these aren't particularly clinically significant, but these ones are, because these can rupture. These can rupture. And what we will do over the next few weeks is we're going to talk about something called the portal caval system. And we're going to talk about portal caval anastomosis. And we're going to talk about things like esophageal varices, capitate Meduse signs. And so this will really kind of link into all of this. So this is like a kind of early introduction to that theory. So just remember how this venous drainage occurs. And it's really, really important for you, for your general diagnostics, when you start to, you know, I mean, as an osteopath, your patient comes in, the first thing you do is a general health screening, and you're going to check, you know, going to check their pulse, and they're going to check their blood pressure. You're going to see if they've got, you know, portal hypertension, or, you know, if they've got any kind of issues like that. So this is very, very relevant to that. So the right brachiocephalic, which is here, I'm going to go through the real specifics of this with you because it's so important. So the right brachiocephalic, I better get a better color, otherwise it won't be visible. There we go. Is shorter and smaller. So this is the right side. That's this one right here. So right brachiocephalic, smaller and shorter. It descends vertically to unite with the left brachiocephalic vein behind the junction of the first right costal cartilage with the sternum, and ultimately it forms the SVC. So it's just coming down, communicating with the SVC. The left brachiocephalic, which is here, it's longer and larger. The left vein passes obliquely downward and to the right behind the manubrium sterni and in front of the large branches of the aortic arch. So this is important because what we're going to do is we're going to add the aorta and how that communicates. And it joins the right vein to form the superior vena cava. So ultimately, both the left and the right, both the left and the right unite to form our SVC, come down to form our SVC. So just remember, shorter and smaller on the right, descends vertically, longer and larger on the left. So the superior vena cava itself receives blood from the head and arms and chest and empties into the right atrium of the heart. And it's formed from the azygos and both brachiocephalic veins. So that's what it's formed by, and that's what it's draining from. Now we need to look at the next part, which is the aorta, and we're going to plug the aorta in. And there's a lot of things that we need to talk about the aorta because there's lots of interesting cases with the aorta. So the aortic arch. The aortic arch, of course, is formed by the part that we've already looked at, because we looked at the heart and we looked at the ascending aorta last week, and we looked at the right and the left coronary artery, and we looked at the where the left and the right coronary artery come from and where they go, and we talked about coronary artery disease and things like that. So the aortic arch or transverse aorta is a short segment where branch vessels to the head and arms start. So we've got three branches that we need to know. We've got the innominate, which is called the brachiocephalic artery. So brachiocephalic means arm and head. Cephalad is head, brachio is arm, so arm and head. And it supplies the right arm and right portion of the head and the brain. That's what it does. The left carotid artery is going to carry blood to the left head and brain. The left subclavian artery is going to supply the left arm with blood. So these are the three branches: the innominate brachiocephalic, the left carotid artery, and the left subclavian artery. There are many abnormalities or anomalies of the aortic arch, such as something called a bovine arch, where there are only two branch vessels off the aorta. So we're going to look at some of these anomalies. And then what we'll do is when we go through the embryology of heart development, you will understand exactly why these happen and why they occur. So here we've just got a nice image that we can look at this overall. So here's the first part. This is the ascending aorta. And of course, everything before that we've already discussed. So the first branch is our brachiocephalic. Brachiocephalic means arm and head, brachiocephalic. And so the brachiocephalic is going to branch off into a right subclavian artery. And of course, the right subclavian artery is then going to go off and supply the limb. That's supposed to be a limb. Doesn't look like a limb. We don't have 3 fingers. Let's give it 5 fingers. There we go. So that's going to be the right common carotid artery is going to go off to the right side and supply blood to the right side of the head. So it's going to go up there. The left common carotid is going to go to the left side. And the left subclavian artery, again, is then going to branch off and give off to the other side, the other limb. There you go. 3 fingers on that. It's like Homer Simpson. Oh, there, 4 fingers. So this kind of helps to understand how injuries to the superior mediastinum or any kind of impingement of the superior mediastinum has drastic vascular issues because of this this is the beginning, the genesis of the arterial supply. So anything that happens here is going to cause great amounts of problems either to the limbs or, more significantly, to the head. So if you think about things like stroke patients, they have a stroke, or somebody who has to go and have a carotid endarterectomy to remove a plaque because they have a plaque buildup in the right common carotid or the left common carotid. And if it's not removed, it's going to go up and they're going to have a right-sided stroke or left-sided stroke. And of course, that ultimately, if it's the left side, it causes problems on the right side. If it's the right side, it causes problems on the left side because of the function of the brain. And so these are some of the different anomalies that we'll start to look at when we talk about the development. But here's a really significant one here. So, this would be the normal branching of the aorta, the ascending aorta, the arch of the aorta. These are all different variations that you can see. So here you've got the innominate, you've got a right subclavian, right vertebral artery, right carotid, you've got a left carotid coming off the innominate, you've got a left subclavian coming off independently. Here, you've got everything is branching off the brachiocephalic trunk. So you've got the brachiocephalic trunk giving rise to the right subclavian, a bicarotid trunk. So this is a really a major one here because everything is all coming off one point. Very interesting, the differences. So significant ones for you would be things like aortic aneurysms. Very, very common problem. Very common problem. I actually spent 6 months working in vascular surgery, and it was very interesting to see these cases with aortic aneurysms. So an aneurysmal degeneration can occur anywhere in the human aorta. By definition, an aneurysm is localized or diffuse dilation of an artery with a diameter of at least 50% greater than the normal size of an artery. Do you have you come across any cases of aneurysms at all?
Actual cases, or are you talking about?
Yeah, I mean, have you had any patients who've maybe had in their case history aneurysms or anything like that?
I've had one which was a carotid dissection. He was hemiplegic by the end.
Wow. Okay.
So the original onset was, I think it was, he had a hit to the neck, and all of a sudden, when he went in, he started to have a stroke. So he had an ischemic stroke going to the brain because of the vessel being starting to rupture.
Right.
And because they didn't do it in time, he lost basically, I think it was the right side of his body. So now he has heavy paralysis going through the right side. He has a dislocated right shoulder, and he just basically drags his right limbs across, and it's causing him neck pain. That's why he's coming in.
Getting neck pain. So he had a dissection.
Yep.
Wow.
So
So,
that's the other one.
do you understand the kind of mechanism behind why aneurysms occur? I mean, let me give you an example. If, for instance, we were to look at the abdominal aorta, do you know why the aneurysms form essentially? Do you know like the underlying principle behind it?
I'm guessing it's to do with the tunica intima being damaged. And basically, as soon as it's damaged, there's a constant blood flow which goes into the space which is created, therefore causing distension.
Yeah, that's right. I mean, it's to do with pressure. It's a pressure over, and it's a pressure over time. So, I mean, essentially, what happens is with all of us, let's just say this is a healthy 20-year-old's aorta, abdominal aorta. And what you'll see is, I know I'm drawing this with a mouse, but, it's fairly uniform. The walls are, fairly thick. And so thinking about the amount of pressure that goes through this on a daily basis, it's constant. And so what happens is over time, so from, by the age of 30 to 20 to 30, the pressure just increases exponentially. And as the pressure increases, the diameter also increases. So you get a pressure increase and a diameter increase. So by the time you get to kind of 50 or 60 years old, in probably 80 to 90% of people, and certainly within the work that I've been doing over the years, teaching anatomy with cadavers, by the time the cadavers come to me in the lab, they're normally, hopefully, they're in their 80s or 90s. And so what I tend to see, I'll just show you. I mean, a 60-year-old is going to start to get this kind of bulging. It's very normal. It happens. And so what happens is the bulging actually decreases the diameter. You were mentioning about the tunica. So the parts that aren't affected, the thickness isn't affected so much. So the pressure increases, the diameter increases, but what happens to the wall is, if we just had a little cross section, is the actual wall thickness decreases. And now this is a big problem, because eventually what's going to happen is, by the time we get to now, let's go a lot further on. Let's now look at one of my unfortunates that come to my lab. Now what happens is, after time, the wall becomes so stretched that it ruptures. And so this is what we see when we have an aneurysm. And so now what's going to happen is all of the blood is going to leak out. And of course, the aorta is the major arterial supply. And so with the cases of abdominal aortic aneurysms, the patient bleeds out within minutes, because the whole of the blood supply empties out into the abdominal cavity. And so for, like forensic cases where somebody's just suddenly, they've been sitting down and they stood up and then they just dropped down dead. As soon as they open up the abdomen, it's full of blood, because the whole of the abdominal cavity is just filled with the entire body's blood supply. So this is a natural progression. This is a natural progression. There is also a genetic link to this as well. I won't go into the genetics too much today, but there's certain conditions, genetic conditions, which affect vascular resistance. Some very interesting cases that we'll definitely look at in the future, especially if we go through histology together. we'll talk about those.
I'm guessing you're talking about EDS, Marfan's, and those types.
Yes, absolutely. Yeah, absolutely. Yeah. So that kind of, with these conditions, unfortunately, the normal vascular resistance isn't the same. So, you know, in their case, I mean, the wall just degenerates very, very early because they don't have the resistance to pressure. But in the normal person, or in the normal human, we see this kind of, it's around every 10 to 15 years, you see a exponential growth and thickening, exponential widening. Of course, there are things that impact upon this. So things like underlying pathologies. So, you know, I mean, certainly you could have a case of a guy who's 30 years old, which has the abdominal aorta of a 90-year-old, because they've got all kinds of things like chronic hypertension. They may be super morbidly obese, people who are you know, very, very heavy, and put a great deal of pressure on the heart. The heart has to exert extreme forces and pressures, so they expand upon the overall aorta itself. So yeah, I mean, this is a kind of standard model, which, you know, hopefully you and me and the majority of people kind of fit into this group. So by the time we get into our later years, it's without a doubt going to grow. But unfortunately, if we think about pathology cases, and as you mentioned, some genetic cases, you know, a 20-year-old can certainly be right up here. So symptoms of aneurysms, so let's look at them and look at the different types of aneurysms and where they are. So symptoms of a thoracic aortic aneurysm as opposed to an abdominal, because I've just been talking about abdominal ones, but we really need to concentrate on thoracic ones for now. So the symptoms of thoracic aneurysm are most evident when the aneurysm occurs at the aortic arch. And so if I just go back for a moment, so that is occurring here, an aneurysm at this part, an aneurysm within the region of the aortic arch. And as you can imagine, it's not really surprising that we get a lot of symptoms when you think about what's coming off, the brachiocephalic, left common, left subclavian artery, all coming directly off the aortic arch. So chest pain, generally described as deep and aching or throbbing. Most commonly this is the most frequent system found with this. The patient can experience back pain. So this is, I'm going to highlight this one for you. So this is really relevant to you as an osteopath as well, because how many patients coming to see an osteopath for back pain? Pretty much all of them, right? You know, I've got back pain. So back pain, as I'm sure they tell you in your training, back pain is a myriad of conditions. You know, back pain can be anything. It can be related to the heart. It can be related to the kidneys. It can be related to the liver, to the spleen. You know, so that's why we say back pain, and then we have our differential diagnosis to kind of get to the root cause of what's causing the back pain. A cough or shortness of breath. So SOB, very important. Cough is significant. So cough or SOB if the aneurysm is in the area of the lungs. So this is affecting the pulmonary system. Hoarseness and difficulty in pain or pain while swallowing. I'm going to ask you a question about hoarseness. Do you know the reason for the hoarseness?
It's got the irritation of the, what do you call it, the recurrent laryngeal nerve.
Perfect. Exactly. It's to do with exactly that. It's the recurrent laryngeal nerve. It's affecting the recurrent laryngeal nerve, because the recurrent laryngeal nerve is coming down and looping underneath. So it's going to, the recurrent laryngeal, in fact, let me draw it for you. Let's get it in pen, ink color. Nerve should be yellow, shouldn't it? So it's going to come down, and then it's going to loop underneath like this, and then it's going to come back up. So we're going to see it. And so the recurrent laryngeal nerve is going to be impacted. And so that's what's going to cause the hoarseness. So difficulty or pain while swallowing, pain in the back, SOB, especially if it's dealing with the lungs, hoarseness because it's going to compress across the across the recurrent laryngeal nerve, and chest pain as well. And so this is a nice, well, it's not a nice image, but it's a nice one to show you with what's going on with, oh, one sec, let's get my pen working again. Pen. There we go, I'll use a laser pen. So what you can see here, this is the actual wall of the aorta. So this is all of the wall of the aorta. Now, it actually looks really, really thin. And it's not this thin. You know, when you look at a healthy aorta, it's probably 3 times, if not 4 times as thick as this. So this looks almost paper thin here. Really, really, really. And it's massively enlarged. This is really enlarged. I mean, the picture doesn't do it justice really, but so what you're seeing here is the beginning of the enlargement, and then it's just bulging out here, and then it's bulging up the top, and then what they've done is they've just cross-sectioned it so they can have a look on the inside. But it's really bulbous. It looks like the inside of a balloon. And I think this probably is a case that's ruptured. So you can just imagine, if I go back to the point I was making here, you know, from 20 to 30 to 40 to 50 to 60 to 90 years, we slowly get wearing away at the wall to the point where we get to this, where it's, you know, the wall has almost got paper thin. And over the course of the years, I've seen cases where, especially when teaching anatomy to the medical students, and we start to do abdominal dissections, and we start to look at the abdominal aorta, and you just literally touch it with your finger, and it's like a piece of paper. It just breaks. It's crazy. It's really weird. It's really weird. Just how much it degenerates is scary. I mean, it really is. Well, it's not scary. It's natural, isn't it? it's what happens. But so aortic aneurysms. So treatment for abdominal aortic aneurysms. So it's going to look at some of the treatments. There are treatments for abdominal aortic aneurysms, thoracoabdominal aneurysms, and thoracic aneurysms. In cases, they need to have a surgical repair in good risk patients. So these in patients which are hemodynamically stable and actually warrant having the repair done. Have you ever seen, maybe you've seen on TV or YouTube, have you ever seen an abdominal aneurysm repair?
I think they just put like a mesh in between.
Yeah.
The vessel.
It's really amazing. Like if you get a chance to, I've actually witnessed them done a couple of times in surgery, and it's incredible. Yeah, they use a mesh, and they essentially stitch the mesh in, and then form around the mesh, and it's incredible because once the patient's had that done, when they go to recovery, they have to have constant. I think it's like 5 or 10 minutes, they have to have the blood pressure constantly checked to see whether or not there's a leak. Because if there's a leak, then obviously you're going to get a drop in pressure. So they constantly monitor the pressure to look for any kind of pressure drop. But it's an amazing surgery. And I can send you a YouTube video if you're interested in watching it. So surgical repair can involve a few different things. So you can have something called an endovascular stent, or grafting in suitable candidates, or you can have a traditional open surgical repair. This is a much more radical surgery. And here, this is quite a nice picture to just show you what's kind of going on with the aorta. So here we've got the normal aorta. And then here we have a thoracic aortic aneurysm. So you can just see how it changes over time. And then here we have an aneurysm repair. So this is essentially what they do. This is what happens with open surgery or with a stent. So with open surgery, it's resected, and they use what really does look like, to me, when I saw it in surgery, I thought, well, it just looks like the thing that plugs in the back of your washing machine. You know, it feels like it and it looks like it. And so they stitch that in, which, you know, I mean, it's mind blowing when you look at it. You think, well, that could quite easily just plug straight into the back of my washing machine and that would work fine. As opposed to a stent, where the stent is actually placed within the aneurysm itself. So the stent is similar, although it's not stitched in place. The stent has two ends on the stent which have metal fixation. And so the metal fixation just stays open and keeps this patent. And so the blood supply can just run through the stent, as opposed to the open surgery. So what I was saying is it's really interesting looking between the difference between stenting and open surgery, because what happens with the open surgery, as you can imagine, because this is literally stitched on. So once the patient goes back, there is risk that the blood can leak through here. And so, you know, they may have had surgery and the surgery can have been successful, and then they can have a slow leak. It's just an ever so slow leak, and it just kind of continuously leaks. And so what they have to do is they have to keep the patient on monitoring, constant monitoring, to look at the BP over, I think it's 24, 48. I think it's the first 24 to 48 hours. It's many years ago, but I think it's 24 to 48 hours. They have them on close observation, and they're just looking to see if there's any changes in this blood pressure system. And of course, differently with the stent, because the stent, there's no where for the blood to go. So the blood can't track out through the aneurysm because there's no incision, there's no surgical incision. So the blood purely goes through the stent. Now, what can happen is the stent can fail. And I saw that in a forensic case. A surgeon had placed a stent and the stent had failed and the patient died. So I'm trying to remember whereabouts they placed the stent. It may have even been here. I can't remember exactly where they placed the stent, but part of the stent had failed, so it hadn't stayed patent. So it was, it was either this bit, or maybe the whole thing failed. And so the vascular surgeon had done the repair, had placed the stent, and the patient had gone back to the recovery ward and then died. And then it became a forensic case, and the pathologist came, and I was lucky enough to see this. And they removed the stent from the body, and when they kind of placed the stent on the table, one of the ends had collapsed, and that's what had killed the patient. So two different things, but very interesting just to kind of remember between the two. Okay, so I'm just going to continue on to talk about the other structures. Now, this is a really significant thing, the arterial ligament, the ligament arteriosum, the communication between the aorta and the pulmonary trunk. And so this is going to link to our embryology. So this is like a embryology link right here. So I'm going to just highlight this for you. So we've talked about the aorta, and we've talked about the branches from the aorta and some of the clinical correlations to that. We've talked about the superior vena cava and the drainage to the superior vena cava and how that occurs, and a few of cases in relation to that. So now what we need to do is we need to start to kind of link all of this together. So we have a structure called the arterial ligament. Well, the name kind of suggests that it's a ligament and it's attached to an artery, and specifically it's attached to our aorta, and it communicates between our aorta and our pulmonary trunk. So this, of course, is going to be the right side of the heart, and this is going to be, so this is the right atrium, right ventricle leading off to the pulmonary trunk, and the pulmonary trunk dividing off. And so right here, we have this ligament. So it's a fibrous band, and it connects the bifurcation of the pulmonary trunk to the lower concave surface of the aortic arch. Now, this is the bit that you need to know. It is an anatomical remnant of the ductus arteriosus. Have you ever heard of the ductus arteriosus?
I've heard of it, yeah.
And have you heard of the ligamentum arteriosus? Have you heard of this arterial ligament?
Yeah, I think it's got something to do with aortic coarctation as well. So
yes, correct. Yes, it does. So anatomically, we describe it as the arterial ligament. When we talk about it from an embryological point, we think of it as the ductus arteriosus. So it's the same thing, just two names. Ductus because that was what it was originally, and it then becomes this ligament. So it's the remnant of the ductus arteriosus, which in the fetus conducts blood from the pulmonary trunk to the aorta in the fetus. But of course, we don't need that once we leave our mothers, so that closes up and becomes a ligament. After birth, the ductus closes, but not always. Hopefully it closes. If it remains patent, aortic blood will enter the pulmonary circulation and it will produce pulmonary hypertension because we're getting a mix of blood from the arterial system into the pulmonary system. So it's a major problem, patent but ductus arteriosus. So it will enter the pulmonary circulation, it will produce pulmonary hypertension, and it will cause hypertrophy of the right ventricle. Because the right ventricle is going to become hypertrophied because ultimately the blood is mixing and it's having to work harder. Things that can be done is a surgical ligation of the ductus can be dealt with, that can manage this. And a left recurrent laryngeal nerve hooks around the lower border of this ligament. So this is where we see our recurrent laryngeal nerve, which is going to come down and hook around and under and then back up. And so we just discussed about recurrent laryngeal when we thought about aortic aneurysm as well. So that's in relation to hoarseness. So all of this links together. So you just mentioned this, which is co-aortication of the aorta. It's a relatively common defect. It accounts for around 5 to 8% of congenital heart defects. It refers to a narrowing of the aortic lumen. It can be primarily divided into two types. You have infantile, preductal form, and an adult, which is juxtoductal, postductal, or middle aortic. And that's the adult form. The symptoms of a aortication can include early life congenitive heart failure, severe acidosis or poor perfusion to the lower body. So again, this is something, especially within your profession, when you examine patients, so many things that you see in the lower extremities and especially in the region of the foot, give you a very, very comprehensive guide to the heart health of the patient. You can tell a lot about somebody from their feet and indeed from their mouth as well when it comes to infection. Beyond infancy, usually none. However, hypertension, headache, nosebleed, leg cramps, muscle weakness, cold feet, or neurological changes may be seen. So again, cold feet, a devascularization, poor peripheral pulses, poor circulation, all of these classic signs. And so here we can actually see this. This is very clear on this image. You can see the K-aortication right there. So let's look at the nerves and how the nerves traverse and where they are and how they're positioned and how they're positioned in relation to everything else. So we've got the left recurrent laryngeal nerve. It's a branch of the left vagus nerve. It loops around the aortic arch and enters the tracheoesophageal groove. And compression of this nerve causes the vocal cord paralysis and hoarseness of the voice. So when your patient presents and they have a hoarse voice, as well as some of the other symptoms that we started to talk about, it's an indication that there is something going on in this region. And it could be a number of things. It could be to do with the aorta. It could also be to do with a tumor formation and growth in this region. So that's also something you see when you see cancerous growth in this region as well. So this is the position of the left recurrent laryngeal nerve. This would be the ligamentum arteriosum. Here's the pulmonary trunk. Here's the trachea, left and right primary bronchi. And so you can see just how close this is. I'm going to ask you a quick question. Let me ask you a quick question. Let's get a different color. What level is all of this going on at?
So I would say T4.
Perfect. Exactly. Perfect, perfect, perfect. T4. So see how significant that is? Huge, right? Mm-hmm. Huge amount of stuff going on right there. Right here, you've got the bifurcation, you've got the arch of the aorta, you've got the pulmonary trunk, the ligamentum arteriosum, recurrent laryngeal nerve, all at that, right at that sweet spot right there. So the phrenic nerve descends over the anterior scalene muscles to enter the thorax, and it originates from C3 to C5. It's accompanied by the pericardiophonic vessels and passes anterior to the lung roots between the mediastinal pleura and pericardium, and it's ultimately going to supply motor and sensory innervation to the diaphragm. The sensory fibers supply the pleura, pericardium, and the peritoneum of the diaphragm. So this is the phrenic nerve, really, really important phrenic nerve. And so here we can just see how the phrenic nerve gets there. So here we have C2, C3 down to C5, spinal nerve C3, 4, 5, keeps the diaphragm alive. So C3, 4, and 5 keeps the diaphragm alive, because that's going to be our phrenic nerve. So these are the origins of the phrenic nerve. So this is our left phrenic nerve coming down. Left phrenic nerve is going to supply the left side of the diaphragm. The right phrenic nerve, C3, 4, 5, keeps the diaphragm alive, coming down to supply our right side of the diaphragm. So a little bit of clinical correlation for you here. If a patient is having surgery to the neck and the surgeon inadvertently damages the phrenic nerve, the patient is going to lose. Remember that the diaphragm is responsible for 75% of overall oxygen or overall functional range when it comes to the lung. So if you cut the phrenic nerve, the right phrenic nerve or the left phrenic nerve, you lose 50% of 75, which is 32.5, right, percent of function, pulmonary function. So is that right? 32? No, it's not. 37.5, isn't it? My maths is useless. Yeah, half of 75. So, and the remaining part is via the intercostals. So this is huge because now, you know, you've got the surgeon is doing maybe a biopsy or is removing a tumor or is doing some kind of surgery in this region, and they inadvertently cut this phrenic nerve. And so you get something called unilateral diaphragmatic paralysis. Bilateral diaphragmatic paralysis is a terrible thing because it means that the diaphragm is completely not working and the patient can't ventilate at all. So they're going to have to go on a ventilator because the diaphragm is completely gone. If you lose half the diaphragm, you're going to lose half of the 75% function. In the phrenic nerve and the left phrenic nerve, let's look at them, and then let's look at then let's look at paralysis. So the right phrenic nerve passes along the right side of the right brachiocephalic vein, the superior vena cava, and the pericardium over the right atrium. It passes anterior to the root of the right lung. So it goes right over the root of the, over the anterior part of the root of the lung. And it descends on the right side of the IVC, the inferior vena cava, to the diaphragm. The left phrenic nerve descends between the left subclavian artery, the left common carotid artery, and it is in position anterior to the left vagus nerve. So it descends anterior to the root of the left lung and it runs along the fibrous pericardium, which we talked about last week, superficial to the left atrium and ventricle of the heart, and most branching of the phrenic nerve occurs on the abdominal surface of the diaphragm. So why is it important? Well, it's important because if we take it back to the case that I kind of, I made up, and I said, if you have a patient who unfortunately had some kind of, even with neck injuries, this can happen. This can happen with neck injuries. So for you, like cases where you get severe trauma to the cervical region of the neck, like whiplash injuries, or T-bone type injuries where somebody's in a car and they become T-boned, the neck flexes laterally. So the neck can be, as opposed to like a head-on collision where the force causes like an anterior and posterior trauma, a T-bone injury, the neck is like a lateral movement. And so what can happen in really severe cases is that in severe cases, when there is so much lateral flexion, you can pull out the nerves. The nerves can actually be pulled. And in some cases, they can either be pulled and stretched and inflammation, which is where you're going to get kind of like intermittent problems. So you're going to get like intermittent problems with the recurrent, with the phrenic nerve. You're going to get intermittent problems with the brachial plexus, things like that. But if you have like a severe, let's imagine a really horrible case where somebody's had, they've been T-boned at a junction, hit really hard, and they've actually pulled out some of these nerve roots. In that case, you could get diaphragmatic paralysis. You could get partial or complete diaphragmatic paralysis. More likely with a one-sided lateral flexion, you're more likely to get unilateral as opposed to bilateral. So diaphragmatic paralysis, whether it occurs in one or both sides of the diaphragm is uncommon, yes. I mean, it's uncommon as in relation to a mechanism of injury. The only kind of case I can really think about is there are rare cases, as I say, with T-bone injuries where this has occurred, and that's because the roots are just literally, it's like pulling out the cables from a computer, they're just pulled out. In patients where one side of the diaphragm is paralyzed, the paralysis occurs in the left and right side with equal frequency. So it can happen either side. And so unilateral, as opposed to bilateral paralysis, I'm going to show you how this appears and show you exactly why it appears the way it does. So unilateral diaphragmatic paralysis is often discovered incidentally in patients undergoing chest radiography for some reason or other. Patients usually are asymptomatic at rest, but experience dyspnea upon exertion and have a decrease in exercise performance. So this could be a young male, a young football player. He may actually have unilateral diaphragmatic paralysis. And you're thinking, but wait a minute, that doesn't make sense because the diaphragm is responsible for 75% of overall pulmonary perfusion or control of pulmonary perfusion. So if we lose that, surely we're going to get much more radical changes. Not always the case, because what can happen is the respiratory system will take up the lack. They'll take up the strain and it will work. So the other lung and the other side will become increasingly functional. It will take up the additional strain, but not so the case in patients. So if you have a patient who's got unilateral diaphragmatic paralysis and they've also got underlying lung pathology like COPD or something else, then they are going to have drastic changes. And certainly in patients who are undergoing surgery and who, for instance, like our neck surgical case, and the surgeon accidentally cuts through the phrenic nerve, which it does happen, the patient who's on the ventilator, you are going to see that straight away within the oxygen saturation levels. So you can get this unilateral diaphragmatic paralysis often discovered incidentally. So this is something that you can come across while looking at your patient's radiographs. They can be asymptomatic, but they may be coming to you. So this could be your football player that comes to you and says, it's weird, I'm just getting problems. My VO2 max, I've been to see my sports doctor and he says that he doesn't understand why my VO2 max is changing. I don't know what's going on. So as I say, if the patient already has an underlying lung disease, this will become more evident. Some patients may also develop things like orthopenia, which is less intense than bilateral diaphragmatic paralysis. And so this is what we're going to see in unilateral diaphragmatic paralysis. So here we can see a normal X-ray. So you can see the right cupola of the diaphragm here, and you can see the left cupola of the diaphragm here. You can see the borders of the heart. This is the apical region of the heart. You can see the costodiaphragmatic recess, really nice. Costodiaphragmatic angle, real nice. All of the lung fields are full. You can see the apex of the lung filling on the right side, the apex of the lung filling on the left side. So all of these windows are good. All of these windows are normal. The chest expansion is good. The rib expansion is good. Now in this one, we see a totally different story. So now what we see is a really high really very high border of the right cupola of the diaphragm. This is extremely abnormal. So this is a normal, and this is an abnormal picture. So the costodiaphragmatic recess, which would normally be here, is right up here. You don't see the normal expansion of the chest. The left side is normal. So the left side, you can see the costodiaphragmatic angle is normal. However, this overall left lung, the size of the left lung is massively decreased as opposed to the normal one. And again, on this case, we can see relatively normal, although again, this is higher, raised, and you can also see some, it looks like on this particular case, although it's zoomed in a little bit, it does look like the heart is somewhat compressed as well within the chest. So yeah, this first one to here, this is really significant. So this is a unilateral, this is a right-sided phrenic nerve diaphragmatic paralysis, unilateral, one side. So the phrenic nerve has been damaged significantly on this side, and we can see that. Bilateral diaphragmatic paralysis, as opposed to unilateral, patients typically present with respiratory failure. They're going into respiratory failure because you've lost all of that 75%. It may be interpreted as a sign of heart failure that worsens in the supine position. Tachypnea and rapid shallow breathing occur when the patient adopts the recumbent position. Patients also report anxiety, insomnia, morning headache, excessive daytime somnolence, and fatigue and poor sleep habits. And in patients, some patients get non-specific GI symptoms such as heartburn, regurgitation, nausea, and epigastric pain. And that is all to do with this close relationship of the esophagus on the posterior aspect, all at the level of T4. So I'm going to just go through the vagus with you, and then we shall finish off for the day. Okay, so the vagus nerve, it has both sensory and, let me get my pen, has both sensory and motor components. So we're going to just look at the vagus nerve, how the vagus nerve transmissions, and then I'm just going to give you a brief snapshot of how it then goes on to the rest of the body systems. It mediates phonation and swallowing, elevation of the palate, taste, and cutaneous sensation from the ear. So I'm just going to link this for you because you've got your exam in next month, and we're going to start to look at head and neck. All of this is going to link. So when we go through our neurodiagnosis, I'll just put ND. When we start to go through our ND lectures, our neurodiagnosis lectures, which we can start going through those soon, because there's a lot to do with cranial nerves and things like that. So that all links to this. That all links to that, because you're going to be testing for phonation, swallowing, seeing if the patient is able to swallow, seeing if the patient can move the tongue and things like that, even if the patient can hear, all of these tests. The vagus nerve also innervates the viscera of the neck, thorax, and the abdomen. So I'm just going to show you the position of the vagus nerve. So we'll look at the left vagus nerve. So here we have the left vagus nerve. We have the superior vagal ganglion, the inferior vagal ganglion, and then the vagus nerve comes down, and it goes through something called the carotid sheath. And so within the carotid sheath, you have the vagus nerve, the carotid artery, and the jugular. And so the whole thing comes down, and it communicates with the heart, and it gives off something called a cardiac plexus. It also gives off a pulmonary plexus. It also gives off an esophageal plexus and a celiac plexus, and then it continues onto the abdomen. So for now, don't worry about this. Just remember that it has a communication with the lungs and with the heart, and it's coming down through the carotid sheath, and ultimately it gives off a recurrent laryngeal nerve, and the recurrent laryngeal nerve is going to be important because that's going to be related to your hoarseness. The left vagus nerve, it enters the thoracic inlet between the left common carotid and subclavian arteries posterior to the left brachiocephalic vein. So the left and right are different because, of course, the left vagus nerve is going to hook around in a different part. So it crosses the aortic arch where the left recurrent laryngeal nerve branches off, as we've talked about. It passes posterior to the left lung root. It forms an anterior esophageal plexus because it's going to innervate the esophagus. It forms an anterior vagal trunk at the esophageal hiatus where it leaves the thorax and passes into the abdominal cavity. And from there, it divides into an anterior gastric and hepatic branches, which we don't need to worry about today. We're going to look at those much, much later on. The right vagus nerve enters the thoracic inlet on the right side of the trachea, travels downwards posterior to the right brachiocephalic vein and the superior vena cava. We know where the position of that is. It passes posterior to the right lung root, and it forms a posterior esophageal plexus. I'm just going to give you a really quick note to take home on that. It forms a posterior vagal trunk at the esophageal hiatus where it leaves the thorax and passes into the abdominal cavity. Then it divides into posterior, gastric, and celiac branches. So a quick snap note, the difference between the left and right vagus nerve in relation to the esophagus. So the right vagus nerve is found on the posterior part, as opposed to the left vagus nerve, which is found on the anterior part. So left vagus nerve communicates on the front, and the right vagus nerve correlates to the back. And you're thinking, why is that important? Why does it matter? It's completely to do with embryology of the heart, because in the beginning, they start out parallel, and then it turns. You've got something called folding that happens. You've got cranial and caudal folding, so the head and the tail folding in the embryo, and then you have lateral to medial folding, so that everything folds inwardly and cranially and caudally. And the organs, as the organs start to develop, they are also folding, but the organs don't just fold inwards, they fold and rotate. And as they rotate, they drag the vessels and the nerves with them. So that's why you get these rotations. So that's just kind of cool to see. So this is the last slide I'm going to show you. And so this just gives you, this is an overall schematic of the whole of the vagus nerve. Now, this is like a lovely endpoint right here, because when you think about the vagus nerve, the name vagus means the wanderer. It's the wandering nerve. And this picture really shows just how significant it is. So look at the way the vagus nerve traverses over the entirety of the body. And so you can have all kinds of complications within the gastrointestinal system, which are related to the divisions of the vagus nerve. So very, very interesting. So when we start to kind of go into the abdomen, and we start to look at pathologies within the abdominal region, and we look at the sympathetic and the parasympathetic system, we come all the way back to this picture again. So we come all the way back to the beginning. And so what we do, and what we will do, is we will map out the whole of the sympathetic and the parasympathetic pathway. So eventually you'll have a complete understanding of the entire pathway and of all of the plexuses. So, you know, at the moment, all we're looking at is the cardiac plexus and the pulmonary plexus and the esophageal plexus. These are the only plexuses that we're looking at right now. But eventually we shall start to go down and look at the gastric, ganglion, superior mesenteric, inferior mesenteric, splenic branches, colonic, hepatic, renal, pyloric, and start to look at how all of the systems. So this is the underlying fundamental principle of system-based anatomy, is to understand how the systems, but in order to understand the systems, you have to understand the basics, the basic principles of how the nervous system works, sympathetics, parasympathetics. And it looks complicated, but it actually, once you go through it a few times, it's not too bad. It really isn't, Manny. It's not too bad at all. So I know we've covered a load of stuff, so I'm just going to give you a really quick snapshot of just some take-home messages, because I know you're going to go away and read about all of this and review it all. So we talked about a lot of stuff today. We talked about the function of the chemoreceptors, and we started to look at how the chemoreceptors work in relation to inhalation and expiration, exhalation. We looked at the muscles. We looked at how the exhalation and inhalation sequence of events occur. We considered one pathology, which was asthma. We also linked that to something that we talked about before, which was bronchiectasis, and we kind of discussed the differences between that. The major part of today was to look at the mediastinum and was to look at the different parts of the mediastinum. And so we linked the mediastinum into our earlier session, where we had discussed important levels such as T2 and T4, T8, T9. And so we looked at how the great vessels from the mediastinum communicate and how they communicate with the heart. And then we started to look at the pathologies of the superior mediastinum. And then also we started to just begin to discuss some of the embryological differences, which we can talk about as well. We also talked about pathologies of the aorta and things like aortic aneurysms and how that significantly changes over time and how we can do different types of repair to manage that. And then we also started to introduce to you how the arterial system links with our understanding of embryology. So when we go through in our next session and we look at the development of the heart, we'll look at how these things work and discuss that. And we've just begun to talk about the parasympathetics and the sympathetic nervous system, which we're going to continue to go through. So there's a lot of link to the stuff I'd like to do with you when we start to cover neurodiagnosis. I'm going to bring it all the way back to this again when we start to go over that. Good. Any questions?
Generally, everything's been covered pretty much.
Good. Did that help? Was that useful, what we covered today?
Yeah. I mean, the stuff about the, say, for example, the asthma, the different irritants, and basically going into further. So, say, for example, if someone says asthma, it's better to clarify what maybe the causation is. On top of that, looking at the great vessels, you reiterated a few points regarding the coarctation, which I forgot for a bit, which was that ligament, which does do the communication between the pulmonary system and the system, the circulatory system. So it kind of basically reiterated that point and brought it back into my head. So it was really good, really nice.
Brilliant.
And this is just going to link on from what we talked about, the thorax and the divisions of the superior mediastinum, and then we're going to just go up into the neck and start to look at the deep structures and then eventually we're going to go into the skull and look at the brain and the different areas of the brain and the cranial nerves. So what we've done here is we've just got a hemisection, and we can see at this cross section we're at the level of T4. So if we go right to the back, we can actually see that we've cut through the fourth vertebral body. So this is going to be the fourth vertebral body, T4, and of course posterior to that, behind that, we're going to have the actual spinal cord. So there's going to be the spinal cord. We're going to have the spinous processes and the transverse processes, which we're going to see either side. And then anterior, this is going to be dressed by the anterior longitudinal ligament, and we can see the esophagus. So this is going to be the esophagus here, and then either side we're going to see the left and right branching of the left and right primary bronchi, which is going to be coming off the trachea and the carina. Now what we can also see is we can see the pulmonary trunk, and we can see the aorta. So this is going to be the actual arch of the aorta that we can see here, and then we're going to see the branching coming off the aorta. We've got the brachiocephalic and the subclavian, which we cut through, and then we're going to start to look at the carotid and the internal external carotid, and the same on this side. We can see the branching and then the subclavian, which is gone. What we can see here in the region of the neck, we've got the carotid sheath, which we looked at in the other video from the posterior aspect, and within the carotid sheath we can see the carotid artery and the jugular, as well as the vagus nerve. And the vagus nerve on the left side, of course, is going to come down and flip around and is going to become the recurrent laryngeal nerve, which we can see here. And on the anterior aspect, as we start to look, we've reflected some of the muscles, so we can see the platysmal muscle, which we've moved out the way. We've got the sternocleidomastoid muscle, which we've cut through, and we're going to start to explore the upper part of the anterior triangle of the neck in the next couple of videos. But what I just want you to draw attention to is just the trachea, and we can see the trachea here. And as you'll remember from your thoracic, we talked about the levels T2 and T4, and how at the level of T4 we've got all of this stuff going on. So now we can really see here on this prosection, we can see how the trachea comes down and splits into two, which is where we can see here. We can see the left and right side, and of course the esophagus at the posterior aspect there. And so it just kind of shows you a nice example of how all of this looks. And this is the kind of imaging that you're going to see when you look at MRI or CT imaging. And as over the next few videos, what we'll do is we'll start to go deeper into the neck and look at some of the muscles and the anterior and posterior triangle muscles of the neck, and then into the head.